started? So, Laura, are you going to put Jemsek Gems on the blog as a link? Or social media?
Hey everyone, welcome back for our 17th live stream. We're thrilled to be here today to discuss some of the issues and challenges that kids and adolescents are facing and some ways that their parents can help them through this difficult time. Before we get started, I'm going to introduce myself. I am a Lyme literate. My name is Julsey Capon, forgot to say that. I'm a Lyme literate psychotherapist, and I specialize with working with children, adolescents, and young adults to help them cope with the social and emotional effects of tick-borne illness. I'm also a longtime patient of Dr. Jemsek, so I can very much relate on a personal level to a lot of the things that my patients are struggling with. So before we get started on the awesome questions you guys sent in, I'm going to introduce my good friend and colleague, Candace.
Hi, my name is Candace Willett, or Candy. I'm the pediatric provider here at Jemsek Specialty Clinic, working with a lot of families, particularly 25 and below is the age group that I focus on and collaborate with Dr. Jemsek and our colleagues. And I'm grateful to be doing this work.
Good afternoon, everyone. I'm Dr. Jemsek, Joseph Jemsek, and this is our 17th live stream, as Julsey said. I'm so proud to be working with Julsey and Candy. It's really a thrill to have such qualified and capable individuals here doing this with me. We hope to do another live stream next month. That'll be our 18th in 2 years. So I'm very pleased with this accomplishment. I hope that it's helped some of you out there who have been listening and following, and very much appreciative of the audience. Our goal and priority is to provide useful information, basic information, to the population, as I understand above all that our patients can't access care. They're either too sick to travel, they can't afford to travel, they can't afford to come here, although we're a value at any price, and we are moderately priced, as most of you already know and appreciate. We spend a great deal of time with our patients. But some people just can't, in fact, the majority can't get here, or they don't want to come here. They've been told by patients, you need to go here, or you need to go there, and they just can't take the initiative to do that. One other thing we want to do in terms of our goal and our mantra of helping people is to start a program called Jemsek Gems, and this will be on social media very soon, and it's going to consist of factoids about Lyme borreliosis complex, and there'll be 60-second vignettes. So, but there are going to be a lot of them, and it's going to be hopefully able to answer a lot of the questions you have about all the perplexing symptoms that can occur with this illness, and there are literally thousands of them, and we're going to try to demystify them and present them in a way that's going to be fun. And I'm going to have to change my shirt probably quite often, so I don't wear the same thing as we do 10 interviews. But I have to bring a change of shirts and coat. Today, after the live stream, we're going to post Julsey Capon's advice, parental advice to kids, how to handle kids that are acting out or sick, and it's wonderful. So as a counselor, she's come up with some very sound, basic, common sense advice, and that will be posted as a link on our blog section. And finally, if you remember, Candace and I, as well as 3 or 4 other colleagues, past and present, put together for the very first time observational review of signs and symptoms in children, pre-adolescents, and post-adolescent children, stratifying everything by age. And that's never been done before. That's already in the blog, but it's going to be reposted on the blog as a link. And I hope you look at it. And one of the things I'm very proud of is that when we have a potential new patient, who's a pediatric patient under 25, our scheduling staff has been sending this information to the parents, and I think they very much appreciate it. It's very helpful. Keep in mind that all categories are not created equal, but the more boxes you check, more likely that you're dealing with a tick-borne illness.
All right, let's get started on the questions. The first one is for Candace. What is your general approach to treating pre-adolescents?
So very similar to what we do for the adults, our focus is very clear. We gather information at the first visit, and we're identifying chronic debilitating symptoms, which we then focus stabilization activities on and detox measures, knowing that this disease is inflammatory. So we can concentrate on means that will help reduce systemic inflammation. Thereby combining treatment in the future, we use detox, stabilization, and antibiotics, including antimicrobial agents and herbal agents to help address this infection. And each has a critical role. It can't be accomplished without the other. And our children and pre-adolescents and post-adolescents do very well in treatment and work towards remission of symptoms.
Do you have anything to add, Dr. J, or should we move on?
I'll just quickly add that, thank you, Candy. The outcome with children can be very, very good, and I appreciate what Candy does and what Tara Fox did before her, because in reality, as everyone realizes, we're treating parents as well as children when we have the family there.
Dr. J, do children typically heal faster than adults, and what would you say is the average length of treatment for children and adolescents?
Well, I'm going to defer some of this to Candy, but I can just tell you in general that the treatment period for adults, once they're stabilized, and the stabilization period can take 4 to 12 weeks. For example, you might need your gallbladder out. We need to control pain. It's been difficult, but we'll find a way without using narcotics, by the way. Sleep issues are important. We have to check your laboratory outliers. And sometimes somebody has to seek out a support person. Those are key. But once we get rolling, we do several cycles, and they're generally a few days a month with pulsing, which we originated, by the way, here at JSC. And so 12 to 15 months, whether it's oral or IV, before it goes to maintenance. We actually have a happy bell in our hallway, so when people go to maintenance, they get to ring the bell, they get to take a video of themselves. It's a happy day.
In general, our children and our pre and post adolescents do very well with treatment, just as Dr. J mentioned. Typically, their course of treatment is a bit shorter than the adults, knowing that they have much less infection. They've had much less exposure than any of us as adults, having a lifetime of exposure to this disease. With that being said, it also allows us to modify treatment accordingly, making it more individualistic and addressing the needs of the patient specifically and what's going on and what they do and do not tolerate very well too. So children typically do very well, again, even using herbal agents too. And again, we're always considering the individual too and what the child needs directly.
Candace, didn't you have for the youngsters, and I'm not sure up to what age, we don't do the 1-year therapy sometimes, correct?
Correct. So depending upon the age of the child, their presenting symptoms, their exposure, even where their immune system is developmentally too, we consider what mode of treatment would be best. So there is a continuous regimen, which typically consists of 8 weeks of continuous antibiotics, then taking 2 weeks off, reevaluating where the immune system is and symptoms experienced on treatment. And then the alternative is pulsing, which we do predominantly with adults, but also pre and post adolescents. That seems to address infection best for them, allowing their body to have time off and focus on detox and stabilization measures. Yeah.
So bottom line, it's all about getting the immune system ahead of the pathogen horde, I call it, and keeping it there.
What are some of the social issues that children and teens are facing when struggling with Lyme, and is there anything as parents we can do to help? Yeah, so the social isolation that comes along with this illness is so real and is so detrimental. And this is how it starts. This is the most common scenario I hear about every single day. You get sick, and your friends are supportive at first. They're still there for you. They're still inviting you places, but you're too sick to go, so you say no. And then you start to feel guilty about always having to say no. And then your friends get tired of hearing no. So what happens? You naturally drift apart. And then on the very rare occasion that you do feel up for leaving the house, you go to the mall, the movie, someone sees you out, or you post on social media, you at the beach, and people say, oh my God, you look great. I'm so happy you're better. When in your mind, you're really thinking, are you kidding? I feel like crap still, and this trip to the mall will take me 3 days to recover. My favorite line I've ever heard is, Lyme patients are not faking sick, we're faking being healthy. I feel like that could not be more true. That Lyme patients have become experts at putting on a brave face and pretending like they have it all together. And so what happens when they finally do re-enter the social world is a lot of anxiety. Look what's happening with the kids because of the pandemic right now. They've been isolated for a year. They reintegrate. They forget how to socialize. They forget how to even ask a friend to come over. So think about these Lyme patients who have been sick for 5-10 years and haven't engaged socially. So my biggest piece of advice for parents is, while your kid is going through treatment or while they're not feeling well, encourage them to stay in contact with at least one person. It could be even a few texts a week or one FaceTime call a month, just so they maintain those social skills. Practice a reciprocal conversation, asking them, how is your day at school? What are you and your friends doing over the weekend? Those skills can be very easily lost. Another suggestion is push them to have a friend come over. I know they're probably not up for going to an amusement park or doing something crazy, but have them come to their house where they feel comfortable, in the privacy of their own home, and keep the play date, or however you want to phrase that, short. So tell the friends' parents ahead of time, can your kid come over, but at 4:30 we have to leave for a dentist appointment. That way your kid isn't worried about, well, what if I feel sick and then I have to tell my friend to go home? There's a concrete end point, and keep it short. And also plan a structured activity. So kids are way more comfortable when both parties are focused and engaged on something structured. A board game, an art project, cooking, baking, even watching a movie. It makes them feel a lot more comfortable. I know that was a lot of information I just threw at you, but did I miss anything?
No, I think that was fantastic. And to emphasize to parents too that there is support, just as who Jules is, a Lyme literate therapist. There is support out there too. I believe there's ways that we are engaging the peers with a Lyme forum too, so that they do have other peers of their age who are understanding too, if the ones they currently have need a little help in understanding this disease. And it's okay to teach them, really. I mean, those that are friendships that you'd value lifelong, they'll be there for you through thick and thin, and they'll want to support you during this time of illness. They just need to know how to do it. They don't know. They're young themselves, but if you could guide them, even guide their parents, if your parent, as a parent, you have a relationship with your child's parent as well, and friends and vice versa, they'll be more than willing to help too.
Yeah. I just like to add that it's a tremendously complex psychosocial issue with interactions between young children, pre-adolescents, adolescents, and adults, adults in relationships, adults that are married, other family members. I'm not in that field, but someone should write a thesis on what happens to family dynamics when there's a chronically ill dependent individual around, because things change. And I saw it with AIDS many times. And I think I've mentioned this before, and Jules and I did a whole hour on this earlier, but it just doesn't go away. And I know that many of you like to hear about this again and get it reinforced, but it's really tough. So we've seen all kinds of scenarios, and I really admire the spouse, partner, parent who sticks with this chronically ill kid who's been told over and over, it's in your head, or there's nothing we can do, you need to go here, particularly to psych. And I like psychiatrists, don't get me wrong. But unfortunately, our specialized system is very judgmental sometimes, and not capable of taking in the broad range of symptoms and signs that our patients have, and we've stopped touching our patients. So we get a lot of referrals from specialists. Well, did he examine you? No, he just talked to me. I mean, so it's like, you're missing half of the interview if you don't have any contact. So there are all kinds of pitfalls, and it makes it very difficult for the affected patient and their support group.
One last thing to add on the social implications is that it's so common that when kids do heal, their perspective on things changes, and so their friendships don't just naturally come back together. They find that they don't have a lot in common with their old group of friends. A lot of times they feel more mature, or they just don't sweat the little things anymore, and they don't want to engage in the petty gossip. So it's very normal that kids feel lost and they don't jump right back into their old circles, but kids are resilient and they will rebuild their social circles. It just takes time.
Great point. Great point.
Yeah, absolutely.
All right, moving on. What are some early warning signs of Lyme or red flags that I should be aware of for my kid?
Sure.
Yeah.
To bring us back to what Dr. J mentioned in the beginning, the document that we put together of the observations, realistically focusing on pre and post-adolescent red flags, realistically what we're seeing as a newborn, as an infant and child during the first year of life, transitioning to school-age child to the adolescent, really tends to focus on big picture stuff, thinking about how was the pregnancy itself. We gather information on that, focusing on what was the first couple weeks like after birth. Was their ability to be able to thrive, or was there a concern for failure to thrive? Any issues with fever of unknown origin as a very young newborn? All those are concerning symptoms, and we hope that primary care would be focused on that too and investigating what's going on. Those things could be indication of kind of a simmering infection or exposure in utero, question mark. As we go through infancy, we're looking at the frequency of infections, focusing more on ear, nose, and throat infections. What's going on there? Potential opportunistic infections like strep or mycoplasma could be playing a part there that later on could have an effect on the immune system. What's going on with how well they're growing and their energy levels? Are they sleeping okay? All of those also affect school-age children too. Now we start thinking more about digestion issues. What's going on with their skin, concerns for any allergies, and that could be to foods, that could be to seasonal environmental irritants. We even think about what's going on with their airways too. All of that is of concern because those could all be related to inflammatory mediators, thus creating more inflammation in the body, thus exacerbating symptoms that could be related to Lyme. As we start going towards the adolescent too, it becomes more predominant what's going on with the mood. As you know, adolescents, they're gearing up to become a teen, to assert their independence. There's hormones going on in the body. So we start thinking about what's going on with their mood. This could be more with pictures of anxiety, depression, OCD tendencies, even going towards the direction of self-harm too, which is obviously very concerning, or controlling of eating habits, how much you're taking in. We could have irregular menstrual cycles starting to crop up, or even kind of like a precocious puberty where we're having an early onset of menses, and that's concerning too. And again, we hope that primary care is taking note of all of these things. There are obviously much more that we could discuss, and I would direct you to our observational document, which we spent a lot of time collaborating together to put these observations together so that they could be red flags for parents to share with primary care or with a specialist that they have built a rapport with, and certainly to share with us too. Again, our administrative staff has been sharing this document with parents who are considering bringing their child as a new patient, and they've had an opportunity to review this, and oftentimes there's different points that might be circled or starred for me during our first interview together, and then we can have a larger discussion about what's going on.
No, I have not a lot to add to that. except that we just have, it's incumbent on us to do a thorough interview and exam. And so that's what we do. We can't gather all this information unless that's done. And that's what we do with each and every patient, regardless of age.
What are some helpful parenting tips? I created, Dr. Jemsek referenced this earlier, a simple parenting worksheet, 10 helpful tips. They're going to post that after the live stream, but I'm just going to run through them really quick. I won't spend too much time on it. The first thing, and this is probably the number one thing kids tell me that bothers the crap out of them that their parents do, is they're so toxically positive, as they call it. So they say things like, you'll be better after treatment, you'll be better in 3 months, everything will be fine. And they're sitting there like, well, you don't know that, you can't promise me that, and 3 months go by and I don't feel better, so then they feel lied to. So it's better to say something along the lines of, we can't predict the future, let's stay hopeful, let's take it day by day, as opposed to false promises. Allowing honesty, another important one. So kids often tell me they get scared or nervous to tell their parents that they're not feeling well, because then their parent will say, well, then you shouldn't have a sleepover tonight, or you shouldn't go hang out with your friends after school, you should rest. But really, they can do those things even despite feeling sick. So allow honesty without the fear of repercussions. Bad memory. Memory issues are real with this illness. So if they forget to take their meds, forget to do a homework assignment or a chore around the house, try not to beat them up too much about it, and don't give them too hard of a time for it. The Lyme rage. Walk away during an outburst, or sit with them and just hold them. Trying to argue back and forth with them or reason with them during an outburst will get you nowhere. Overstimulation. A lot of times, restaurants, crowded places, big parties are very hard, and they get very overstimulated. So if they don't want to go, if they say, I really prefer not to miss this party, let them. Don't push too hard. Consulting with them on some medical decisions, probably not an option for the really young ones, but if it's an older child, adolescent, they really feel better if you include them in some of the decision making and ask their opinion on their treatment plan. Cutting them a little bit of slack with school and homework, not too much slack, but if you know that they really need a rest day or they just can't stay up all night studying for that test, it's okay. Their health comes first. Unhealthy sleep patterns. Kids often, as I call vampire, they're up all night, sleep all day. Parents say, stop being so lazy, turn off your tablet and just go to sleep. They really can't control it. Dr. J is going to touch on this in a little bit. Food sensitivities. They're not just being picky eaters. They really do have certain sensitivities, and they're not faking that. They're not just trying to get out of eating their vegetables. And extended family, warning cousins, aunts, uncles, parents, friends that my kid is struggling. Please don't say things like, you look great. It makes them feel invalidated. So giving them a heads up on some of their emotional and physical limitations before entering the house is super important. So again, we'll post this after the live stream today. Okay, move on to the next question. All right. The sleep. What is the best way to manage sleep problems? My child is up all night and sleeps all day.
Short answer is you can't do it. They have a non-24 circadian rhythm, and there have been alterations to the hypothalamus, which is control over sleep, through a hormone called orexin, which is our awake hormone. There's even a drug on the market which limits or inhibits orexin. So when we have this situation, the first thing we want to know is, do they have an inverted adrenal axis? In other words, when we get up in the morning, our adrenal function, our cortisol level should be highest and then the lowest at night. Probably the best way to check that is do a salivary cortisol test. It's very hard if somebody has an inverted cycle and they're going to bed at 4 in the morning. And what's interesting is there's some young people who are so severely affected, and older people too, and young adults, that they'll ratchet through their non-24 circadian. So one night they go to bed at 12, another night for a couple nights, and then it's 2, and then it's 4, and then it's 6, and then it's 8 in the morning. It's unpredictable. And if they're in treatment with us, we just want quality sleep during that period of time. And thank goodness you're in an environment where you're living with people supporting you and caring for you who can tolerate your sleep patterns, because we can't fix that. If they have an inverted adrenal axis, we have to be patient. The way to get them better is to treat the disease and allow those structures to heal. The hypothalamus and pituitary in particular, sitting at the top of our limbic system, are critically important to so many functions. All the hormone functions, has to do with our sleep, has to do with our hunger, has to do with our sex drive, and so many functions that are altered. So, people with this disease can feel like, well, I'm on another planet. I don't belong here, and you're on the wrong planet. But there are sleep meds that help get to sleep, but I don't think they're appropriate. But Candy may have some ideas about how to help the youngster who really can go to bed at 10, 11, and 12 or 1, but can't get to sleep and doesn't want to go to sleep. So I'm going to kick it to Candy.
Sure. Depending upon the age group, realistically, we're always starting with natural first, and using things like antihistamines too, or melatonin, and making adjustments accordingly. Sometimes we have to go towards prescription medications, but those that are very safe and well studied and have safety and efficacy established. But realistically, being able to help with sleep initiation and maintaining sleep, that's ultimately the best we can do. And just as Dr. J mentioned, really having a block of time that's dedicated towards sleep, and based on what the child needs developmentally too. There are particular hours of sleep that are necessary for the body to heal itself, for it to recover, for it to acquire deep sleep so that you can clear out toxins from the day, even to allow the immune system to help heal and recover. And children also grow in their sleep, and their brain continues to develop in their sleep. So all of these things are highly important as the brain continues to develop all through the spectrum of birth to young adulthood. And that's just as important for the adults too. They certainly could benefit from adequate sleep too, to be able to help towards detox measures, to help with healing and recovery. And when that's out of balance, we really do risk further destabilization. So that's a huge focus for us.
Yeah,
anything else, Dr.
Yeah,
J?
just one other thing. I think it's so important to get quality sleep, regardless if you're going to bed at 11 o'clock or 8 o'clock the next morning. And so sometimes we'll medicate people. What time are you going to bed? 4, 6? Okay, let's medicate. You're going to sleep till 3 the next afternoon. I want to make sure that they get some delta sleep, which occurs early in the cycle for almost everyone. There are other sleep conditions such as narcolepsy and cataplexy, which do occur, but for that you need to see a sleep specialist. But it's so important that deep sleep is achieved, and there's smartwatches out there, and I'm not selling smartwatches, and I want you to make your own decision on that. But I think they help, and the good ones. So, and I've got lots of patients doing it. They figured it out on their own. And you can see from the marketing that it's a big deal with Apple, Fitbit, Garmin, some of the others, and that's helpful. Gives you some information, so little data. Look into that.
Dr. J, what is the best way to get my child accommodations at school?
So we're going to talk in a moment about what to do about recommending school at all. Accommodation. So to continue, if the young person is going to school, and we'll talk about the pros and cons of that and what drives that decision. If they do go to school, private accommodations, because they've got their own lifestyle, and it's not that we want to isolate them, but a private room is good, and then of course a low course load is highly recommended. And we're going to talk about more of that in a minute, but we can write a letter here, and we've been very successful in getting accommodations.
To add on that, some of the most helpful accommodations that our kids and teens get if they're in elementary, middle, or high school are 50% extended time on tests and assessments, taking assessments in a private room to alleviate some of that social anxiety or performance anxiety. Something called a flash pass can be really helpful for our patients, which basically means that they can get up anytime to go to either the nurse, the bathroom, or take a walk in the hallway without having to raise their hand and ask the teacher to leave the classroom. Preferential seating, whether the kid prefers back of the class, front of the class, and ability to have snacks and water with them if that's not already allowed. And permission to wear sunglasses for light sensitivity can be really helpful. And then if you're finding that your kid is regularly missing school, going in late, leaving early, a lot of absences, you might, as Dr. J said, consider a partial schedule. Mornings are particularly rough for our patients, so if they can go in a few hours late, take a few less classes, that can be super helpful. And then this accommodation is a little bit harder to get, but you can work with the school and the teachers on getting their missed assignments excused. That would be really helpful, because what ends up happening is kids miss a lot of school, but then it's really not even a rest day because they have to worry about all of the assignments that they have to make up. So it becomes counterproductive. So they end up pushing themselves to go to school, even if they really do need a rest day, just so they don't have to make up all the work. So getting permission to the missed assignments to be excused can really decrease stress. Okay, where are we? This one is for Candace. What are some remedies or medications to help with my child's Lyme rage?
So realistically, what's going on with the Lyme rage, we think about where is the infection invaded and what system has it impacted within the brain, and that's the limbic system. And with more agitation, we have more emotionality, we can have more sensory overload, we can go from 0 to 60 rather quickly. What we need to do, in essence, is calm the brain. And there's many different things that we do naturally, like GABA with L-theanine I use often. Sometimes we escalate to CBD oil, depending upon families, how comfortable they are. But I'm very confident and comfortable with it as a product. I think it can help calm the brain. It certainly has the potential to be neuroprotective and anti-inflammatory too. Lots of good benefits with it, even calming agitation and improving sleep. If that isn't helpful, I sometimes utilize an antihistamine like hydroxyzine, which can again be very calming, especially if there's a component of histamine as well. And ultimately, as a neurotropic agent, which we use consistently, is lamotrigine. And that's one I use with all ages. I've used it even with those very young as the age of 5. It really just depends on patients' needs and really what is effective for them, because everybody has different demands. The lamotrigine is very safe. It's dosed appropriately based on weight. And realistically, it's dependent upon, again, what the patient's needs are and the dosage that may be appropriate to calm their limbic system and allow for them to have a more stable mood without the lability. And certainly it helps them to decrease some of that emotional stress that occurs in that situation for themselves and also for the family. Certainly may reduce stress for the entire family unit too when this happens. It usually can be brought on very quickly, or families can start identifying what the triggers are going to be for this type of Lyme rage. Even considering what those triggers may be, such as food, overstimulation, more stress, anything else going on in the family dynamic, and trying to minimize those stressors. That certainly is the first least invasive thing that could be done in the household.
So, yeah, that's really good. Okay, so the source of irritation is the amygdala, which is I call the devil gland at the bottom of the brain. And it's out of control. So it's our fight or flight, rage or fear center. And it's not coordinating well because of the disease with the prefrontal cortex. But in children, it's a little bit different, right, Candy? So do you see patterns? So we deal with it all the time in adults. Are children different in that regard? Because I'm sure it's a similar mechanism, but yet the brain hasn't developed
Correct.
In children. So what do you think about that?
Exactly. So I think the difference there is really that the brain is still developing, and certainly children's emotional center is still in development.
So it's even more labile.
Exactly.
I see.
Exactly.
Does it last shorter a period of time in children, or just can go on indefinitely?
It's more predominant during school age, and then also during pre and post adolescence. And then at that point, children have developed more coping strategies too. They are developing more reasoning. They have more control over their emotional center, but certainly this infection just stimulates that particular area. And
so all those good things are in the best situation possible.
Exactly.
Not everybody gets, especially adolescence is a tough time. It can be a tipping point just for the hormonal changes, as well as the societal changes that happen at that age. Thank you, Candy.
You're welcome.
This question is my favorite. I get it all the time. I don't know the proper balance between letting my kid off the hook for things such as doing homework and chores versus holding them accountable for the things they should be doing. Any advice? Yeah, so this is a tough one. So many parents may overestimate the limitations associated with their child's illness, or they have decreased restrictions on activities or household chores. But despite illness, kids still need structure, they still need discipline, and they still need rules. So in terms of helping out around the house, I usually suggest having the parents ask their child, pick 2 or 3 chores that you're going to do this week instead of assigning them something to do. So that way, if they have agency over it, they're more likely to pick something that they know they're physically capable of handling. It can be as easy as filling the dog's water bowl or setting the table, nothing strenuous. But they feel a little bit more in control if they get to pick which chores that they're going to do. Be lenient on deadlines of it. So don't say you have to do it in the next 30 minutes. Maybe give them the full day to do it. And again, that gives them more control. But it's super, super important to implement this because doing simple chores around the house increases the child's confidence, their sense of productivity, and it prepares them for more independent living in the future. And the thing with kids is that they see themselves through their parents' eyes. So if a parent cuts their kid so much slack and say, just sleep all day, honey, don't go to school, don't do, your chores. And I know it's coming from a place of compassion, but what message is that sending the kid? That my parent thinks I'm too sick to do anything. So they start to believe it themselves. If mom doesn't think I can do this or doesn't think I need to do it, why should I? So to help them build the confidence that they're already losing or have lost is so important. You can say things like, I know you don't feel well, but I have confidence in you that you can do your math homework tonight. Or I know you're sick, but I have faith that you can make your bed today. Instead of saying something like, get up, take a shower, clean your room, you'll feel so much better. That doesn't work because they don't feel better. And the goal is not to make them feel better. The goal is to help give them the confidence that they can achieve accomplishments while tolerating the pain and the distressing feelings and emotions.
Yeah, and if I could add, sometimes in my observations, there's a strict and flexible parent, shall we say, for want of a better term, and then there's the warm, cozy parent. So, oh my God, they're in the worst of both worlds, right? Yeah, so the poor kid. And I think the other thing is that this is such a tough area, and I'm so glad Jules and Candy do most of this. But sometimes the kid, I was a kid, and kids can be manipulative. They say, well, I'm sick, I get away with more, I can do more, I can watch more TV, I can work on my, with my iPad or whatever, and just do that all day long because I'm sick. I can't do things. I used to manipulate my parents. I did. I had a piano recital I didn't want to go to one time, and I took some rotten eggs and threw up over the balcony.
Oh my God.
And my parent, it was an hour before. I timed it, so it'd be just about a half hour before we had to go. And I threw up, and I said, I just threw up. I'm too sick to go. And my mom said, oh, you'll be all right. Come on, let's go. And that was the end of that. But I also, so I think it's really tough, a really tough chore. And there's always the balancing act, but Jules has some wonderful advice.
Dr. J, why are so many Lyme patients sensitive to psychiatric meds?
or antibiotics,
yes.
or anything, or supplements.
Yes.
This goes for all patients, and in the developing brain, I think it can be a lot worse. Our meds are designed to upregulate certain neurotransmitters, downregulate others. We have a yin and a yang. We have checks and balances in the neurotransmitters. They all have receptors. The brain is a amazingly complex organ that's just still defies full understanding and deserves all the study it gets. However, in Lyme borreliosis and a few other conditions, you can have toxic encephalopathy. Lyme borreliosis is an organic encephalopathy, meaning it's inflamed. The whole thing's inflamed, particularly the lower brain and the limbic brain. So we have white matter, we have gray matter. And so the white matter just gets hammered, and that's all our essential functions. That's our reptilian brain. That's the brain that does not think. And so we have Lyme range, that brain is not being checked by the prefrontal cortex. So it just goes off, and you have Lyme rage. And so Jules' advice is very key. So unfortunately, neurons are damaged and killed because an infected neuron will die. We have 100 billion cells, thank goodness. Some parts of the brain regenerate, especially the hippocampus, possibly. And other parts of the brain, not so much. But again, with healing down the road, you're going to make more connections, and the brain can compensate for that. If it's not inflamed, it's not infected. Infected tissue cannot heal. So antibiotics can be very quirky. Well, that's why one reason we give them as a pulse, because our targets are long-lived. They're slow to replicate, so we don't need meds every day. And in this case, they create a lot of toxins, and the fire's in the the toolbox, if you will, or the fuse box. So things can go sideways in a hurry. So the stabilization is very important. And if patients have paradoxical reactions, that's one of our roadblocks, by the way. Paradoxical reactions to meds that they start with or have been on for some time. The brain is changing. And so that can halt the patient's progress and halt the treatment. Needs to be understood. It has everything to do with receptors, which are damaged, maybe healing, and ability to get the neurotransmitters to them in a balanced, synchronous way. And that is amazingly complex, and there is obviously a lot of trial and error.
Absolutely. An additional thing to add to that, Dr. J, is what you've emphasized before is the concept of the brain on fire, too.
Yep.
And so certainly that can lead to more paradoxical effect even with meds that I start with the younger patients, too. And sometimes we have to think about just how complex their illness is and what might also be playing a part and what might help with calming the brain in order to intervene and maybe add some psychotropic agents or be able to stabilize their mood once we maybe consider should we be using something like an antihistamine in order to reduce systemic inflammation for them, and thereby once we decrease histamine in general or other inflammatory mediators, the brain may be more receptive to adding other medications or prescriptive medications. Sometimes that's also still a challenge, and we may have to go the route where we're using herbal agents, such as a CBD oil or a GABA with L-theanine, that maybe the brain is better at accepting, and certainly it could be calming for them. So many different things that we consider. Certainly this disease is extremely complex, and so is the nature of the brain, too.
So many professionals continue to tell me that my kids' symptoms are psychosomatic. How do you distinguish whether someone's symptoms are due to Lyme or something mental health related? Really good question. So Dr. J and Candy might have a different answer to this coming from a medical standpoint, and they get to actually examine the patient. I have a patient's history and what they tell me to go off of. So first I ask about their symptom presentation. With somatic symptom disorder, a patient usually presents with headaches, stomach aches, fatigue, sometimes shortness of breath, or chest tightness if there's anxiety involved. But our Lyme patients come with a laundry list of symptoms, and some don't even, you would think they have nothing to do with each other. Like someone could have skin irritation, gallbladder issues, seizures, neuropathy, and you don't typically see that in psychosomatic illness. And then the next thing I gain information about is when and where do they feel sick. So if a child is telling me mornings are the worst, but by second period at school I usually feel better, okay, that makes me think maybe this is anxiety related. It could be separation anxiety from parents, or social anxiety, being nervous and being around peers, or performance anxiety with taking a test. Or if they tell me they only feel anxious, they only feel sick at night, then I'm thinking, is it nightmares? Are they scared of the dark? Do they think someone's hiding in their closet? Or if a kid tells me, my symptoms are worse when I'm at home, but if I go to a friend's house, or if I'm at school or out at the mall, I feel better, then we take a deeper look into the possibility of a toxic household. With our Lyme patients, I find that for the most part, their symptoms are pretty consistent. It doesn't matter what time of day or what environment they're in. Of course, they have good moments, days that are better than others, but it does stay pretty consistent. And then the last thing I like to ask about is, what have they already tried in terms of treatment? So if they've been to extensive psychotherapy, if they've tried psychiatric meds, made lifestyle changes such as diet, exercise, stress reduction techniques, and their symptoms haven't changed, their health is still declining, then it's time to seek out possible alternative diagnoses. Do you have anything to add?
When it comes to the psychosomatic, there's another name for it medically, conversion disorder. That's very famous. A lot of medical providers that don't have an understanding or an awareness about this disease, or choose not to acknowledge it because the testing is poor and insensitive, then we get a diagnosis maybe by a neurologist or a psychiatrist saying, well, they have conversion disorder. And in my line of work as a pediatric provider, I don't know of many adolescents or pre-adolescents or even school-age children that even know what that means and would know how to fake illness as complex as this. So it's not likely conversion disorder, and it's very disheartening to be a child or a teen, even a parent, to receive that diagnosis and know wholeheartedly that something else is going on and has nothing to do with mind over matter, and that they are creating these symptoms or trying to get out of something and avoid school. Children typically like going to school, and they typically like being with their peers, and they typically like engaging in activities, and they don't enjoy having those things taken away or saying, I don't feel good and I don't want to go. But that's not a typical response, that's an atypical response, and that's when we should be paying attention.
And if I could add just quickly, that's the reason to do an examination and to listen to the patient carefully and not dismiss any weird thing they say, because if they say something weird, it's probably neurologic and you've probably heard it before. And they're afraid sometimes to, especially as children, to say they have a certain symptom or a certain finding, like I get a buzz down my leg or my whole body vibrates sometimes. And they're just afraid because they've been told so many times that this is ridiculous, even by parents. They're told that, what are you talking about? Nope, the body never vibrates. Well, yes, it does. Not physically, but the brain signals suggest that the body's vibrating, etc. And there's so many other symptoms of that nature that it sounds so bizarre. But once you learn the dialect, you learn the language, it's like anything else. It starts to come together. You start to see patterns, and they make sense. And then you put your arms or hands, on the patient and do a thorough exam, and you find this, that, and the other that's not normal. And you start to put it all together, and you say, I think the child or the patient is systemically infected, and this could be tick-borne illness. And here's the main 3 reasons why, and then go from there. You glean experience from previous antibiotics was a response of any kind, and you just start checking boxes.
Dr. J, what causes seizure-like episodes, and why do they not show up on EEGs?
So this is a favorite topic of mine. I've seen it for 20 years. Seizures in first of all, I think that our Lyme population, which is millions of people, have the highest incidence number of seizures in the world. Okay, how's that for a brash statement? And here's the difference. It's so simple. It's really simple. Remember I said white matter, gray matter? All the inflammation that causes seizures is in the white matter. And so those are called subcortical seizures, paroxysmal limbic seizures, atypical seizures. They can be called, they have other names for them as well. You can have akinetic seizures, you can have frozen man seizures, you can have seizures in the cerebellum and the occipital lobe. But an EEG, measures the cortex. It doesn't measure what's down here. And so occasionally there's a blip, but usually it's normal, even if somebody's having a seizure. So it causes movement, but you don't get postictal, you don't have urinary incontinence or fecal incontinence, you don't bite your lip, you don't arch your back typically, sometimes you do. And most people are somewhat aware of what's going on, but they can't communicate during the seizure. And so these are called subcortical seizures, and that's what we call them, are atypical seizures. And they need to be treated, and so our combination of neurotropics, antihistamines, and GABA and certain other things all contribute to try to calm down the brain. The brain's on fire. And seizures are very common, but they get misdiagnosed all the time. And here's what happens. The number one name that is given to the patient, who's of course dismissed by the neurologist, is pseudo-seizure. What an awful name. Pseudo-seizure. It's not a real seizure, it's a false seizure. And so they're telling a patient whose body's sore from seizing over and over again that this is you're faking this. This is false. And this is just tragic, quite honestly. The neurologist is missing much of the brain, like a third of the brain or more. They just don't even measure it. And that's where everything's going on. There are other seizures in the brainstem and so forth. Gelastic seizures, dyscrastic seizures, there's all kinds of seizures. We have a term seizure equivalent. So if somebody has an episode, and we can trace it to the parietal lobe, or the temporal lobe, or the occipital lobe, or the cerebellum, or the basal ganglia, or the brainstem, we'll say that's a seizure equivalent because there was abnormal electrical discharge in that part of the brain. That is a seizure. But the EEG won't show that. It never does. And it's a waste of time, quite honestly. And for the life of me, I don't understand why the neurology groups don't understand it. A few of them are starting to understand that, but there's just been a cruel dismissal of patients suffering for many years because the test didn't show it. And that's a theme in our disease and in this illness, which ought to have its own specialty, by the way, is that our tests don't show it. The blood work doesn't show it. Well, what if the tests or blood work aren't sensitive enough or accurate enough to portray what we're looking for? They aren't. And in that case, so there's no disease. Come on. Look with your eyes, examine the patient, and you'll learn. And that's how you learn.
Our final question of the day is for Candace. My child is leaving for college soon, but I'm worried about them moving away while on treatment. What do you suggest?
So hopefully at this particular point when we are moving away to school and we're considering leaving our support system, we're much further along in treatment where our adolescent or our young adult can stand on their 2 feet. And that means that they maybe can take on medication management, that they can take on being able to detox for themselves, organize their diet and make certain that they're eating clean foods and avoiding anything that they might be intolerant to, including being able to take on a new change. Moving away from home is exciting for anyone, but it's also a major stressor. And it's a stressor to start school in a new place. Again, even though it's exciting, it's managing all those tasks at once when they've never been asked to do those things. And just as Jules mentioned, encouraging your child to develop these skills early on is going to be helpful. So then when they're at this point, they have developed some independent ways to care for themselves and are less reliant on you. Ideally, if they are in a place where they've moved along in treatment and now they're on what we would call maintenance, where we're focused more on healing and recovery, less on treatment, they would be on less antibiotics too, as well, so less to manage. And it's all about trying to make this a manageable and positive experience for them, one that they can accomplish, which would also include maybe limiting how much they're doing within the first semester and speaking with their family and their advisor about setting up accommodations, which could mean, just as Dr. J mentioned, maybe having a single room so that they don't have a roommate who's competing with them for sleep, and even music or sound in that room for sensory stimulation. Just being cognizant of all of those things, and as I always encourage my students or my parents, ask for the moon and the stars. You're usually going to get it. Think about what's going to make you successful. That's what you ask for, because in all my experience, the schools, the colleges, the universities, they want their student to be successful. It behooves them for their student to be successful, and to have a positive experience. So that means asking for what your needs are. Think about what you had set up for high school, and now consider what you'll need for college. Some have even gotten a handicap pass so that they can park closer on campus, and if it's a larger campus, there's less walking for them to do, or they have a pass for the shuttle, whatever it may be. Think of all those things again that would help you to be successful managing treatment, medication, sleep, social, school, all of those things. And certainly I think parents are more than happy to be supportive. We certainly are as providers, as is Jules, to get them through and work with them and continue with therapy sessions. All of that makes a huge difference.
Right. Yeah,
anything to add?
So I'd sort of break it down into what is best for the patient, in this case, a young adult. Is it best for them to go to school and for that to engender some self-esteem? Because that's important to them. You realize with this disease, we lose control. And it's very frustrating to people and makes them very angry sometimes that they can't control small things in their daily life. And for a student who's been isolated to some extent, and COVID, by the way, makes this a lot worse. If you're not vaccinated, or you're not vaccinated to the satisfaction of the school, then you're isolated if they let you in at all. It's just been a horrible situation. But however, it boils down to competence versus the benefits of self-esteem. So the competence comes from being well enough to deal with daily life, and maybe well enough to go into an environment with excessive stimulation and excessive stress, because that's what a first year in college or second year in college is. So if it's so important for the patient to go, well, first of all, a lot of our more mature patients say, I'm going to take a gap year or 2 years to get better, and then I'll go. We love that. But other patients, it's so important. They've been robbed of their self-esteem and the ability to control their environment. And after all, when we're growing up as kids, it's all about control, seeing what you get away with. But truly, they've lost control. So if it's important for them to go, okay, let's get a private room, let's have accommodations, let's write the administration, let's take fewer classes, let's make our goals achievable, and preferably, you're not too far from home. But that's the decision I have to help the parents and the child make.
I would also like to add, adding a backup plan is really important, so that if your child isn't able to manage independently and they have to come home, they aren't starting from zero. So maybe do some research on community colleges where your child could live at home but still attend classes, how quickly they could get enrolled in those classes, or even considering a part-time job. Think about that ahead of time, because what happens a lot is if a young adult has to come back home, drop out of college, they become depressed, they have no plan, and they sit and do nothing all day. So figuring out those things ahead of time is important.
It's a great suggestion. I'd like to sign off and say thank you to everyone that's watching or will watch. We're going to continue with this format. We'll have a session. Oh, first of all, I'd love to thank my colleagues, Julsey Capon and Candace Willett, and they really did a terrific job today, I think. But next month, we hope to do our 18th live stream in the first 2 years. We started in April 2020, just the same time COVID did. Actually, COVID started the summer of 2019. Everybody knows that. But anyway, Kim Fogarty and I are going to finish up on the second in a series of how do we treat and why do we treat. And so go back to that first series and review it. We're going to pick up on that and tell you about our philosophy and rationale for the way we treat these very complex patients. Meantime, take very good care, and we'll see you later.